The second part of what I want to talk about before the break is how we plan for success and avoid some of these complications. And I want to begin with really some straightforward stuff. What defines a successful implant restoration? I look at this tooth. Tooth number 1-1 is a metal ceramic crown. It's not a perfect reproduction of tooth number 2-1. The tissue around it, if you look in particular at the distal papilla, it's not the same as the papillae on the distal of 2-1. But first view, there's no screaming problem here that says, hey, look at me, I'm a prosthetic replacement crown. And I've got a very happy patient. So you don't have to be perfect to get an outcome that the patient will be satisfied with. What you need, according to Urs Balser and his group from a consensus meeting that we had in 2003, I had the pleasure of working in the same group as Dr. Racuzzo at this particular ITI consensus conference. The prosthesis needs to be in harmony with the face. So when the patient speaks and talks and smiles from 3 feet and further out, the observer doesn't notice anything that's out of place. The next thing is if you get a little closer. Sometimes that involves talking a little closer. You know, when I talk to my 20-year-old daughter, I was explaining to her the other day that I will always love her because she's my daughter, but that she shouldn't anticipate that that means I always like her, because I didn't like her on this particular day. So you get up close like this, and you need to be able to see and not see any intervention. Healthy surrounding dentition, the color, the shape and form of the periodontium, as Mario said, needs to be right. We do not want to create disease. The next thing we need is a crown that's compatible with the teeth around it in terms of color and form and surface texture, etc. If we get all of those things right, the patient has the illusion that they never lost the tooth in the first place. And that's important because we lose teeth all the time. Failing prosthesis, congenitally missing teeth, failing endodontic therapy. These are the reasons for tooth loss and really the reasons for intervention that involve dental implants. So if we look at these, we have one where the tooth is lost and we make a decision to wait before we do anything. The majority of the time I fall into that category. I like to know what I need to treat before I begin, and I don't like to start treatment and rely on the patient healing in a particular way. I think that adds an unknown. The one in the middle, patient who had the tooth removed, was allowed to heal, inadequate bone volume to place an implant, so we needed to then regenerate and work on the residual ridge. And then the last one is actually a dentist, is this patient, and he chose to take the risk of an immediate restoration because he knew the consequences. He had a low lip line, he wasn't too bothered by the outcome. But what you can see is 3 very distinct pathways to implant placement. Extract and wait, extract and graft, extract and place the implant. The decision here is often made arbitrarily because I heard someone say immediate placement might work for the tissue. No evidence, no support. Or I heard someone say, I like to be more conservative. I'm sure there are circumstances, however, when that is not the best pathway to do. You have to, as a clinician, educate yourself to make the right calls. Then we place implants. The one on the left, flapless. We don't do a lot of flapless surgery either, but I wanted to put it in there to show you that there are some conditions when we do that. In this case, being able to work with the patient to achieve this kind of tissue response is what led it. This is very simply an Essex retainer with a shaped provisional, and this patient falls into a very small percentage category that healed with adequate bone for implant placement and good soft tissue contour. This is made possible for us to do a flapless surgery by the utilization of templates and by the appropriate utilization of CT. I can use a CBCT where I can visualize my planned restoration and say, you know what, we've got good bone in the right place for the restoration that we're looking for, so maybe we can go ahead and perform a flapless surgery. I wouldn't consider doing it in any other way. Then we have a full-blown elevator flap and place an implant, and then, as you saw previously, we have an immediate placement. Difficult surgery to perform an immediate placement because it's hard to visualize where the implant goes. That requires a high degree of commitment from the surgeon. Then the part that's not negotiable, a provisional restoration that's supported by the implant in each case, so that we start to develop an emergence profile, a soft tissue contour, and that's really something that's changed over the years. Then the next thing we are going to do is restore. On the left-hand side, you see a metal ceramic emergence profile abutment, customized because of the tissue, the mucosal phenotype being relatively thin, so we can see the color of our intervention through. So before we had a chance to use ceramic components, we made our own metal ceramic components, but you can see we have a all ceramic crown. In the middle, we have a titanium abutment, and we're going to have a metal ceramic crown, and then on the far left, what I would call a precursor to variobase or tie base. This is a cementable abutment when we are using it as a recoverable abutment. In other words, we're going to cement the crown over the top with an access hole in the back. We're going to pull the abutment back out, and we're going to clean off all the cement and put it back in, the same way we would use a variobase today. And I think the bottom line is each pathway, tremendous variation in how we get from A to B, but an outcome nonetheless that the patient is satisfied with. The key here is you can deviate from some of these pathways. The key ingredient is the clinician, understanding basic principles, incisal edge position, incisal plane, lip support, all of the things that we learned years ago in conventional dentistry are still just as important in today's implant dentistry and even in more contemporary procedures like CAD/CAM. And it's important because, like you, I practice. These are patients that have walked into our office over the last maybe 5 or 10 years, and I look at some of these photographs and I know the patient was very difficult to treat. I looked at some of them and I know the patient was quite straightforward. The important part here is how can we predict the outcome? And the one I'm really wanting to know about is where are the risk factors? Risk factors are important to me because, as I said, I don't treatment plan to fail. I assume we are going to succeed. In order to succeed, I need to minimize the likelihood of risk. So I'm very careful at identifying where is risk. And what I understand is that communication between members of the team and addressing these risk factors before we start care is the important part. Know where you go before you're going there. That's why treatment classifications are important in avoiding complications. Understanding the quality of your team. Some people can and some people can't. And an interesting part here is an anterior segment, we are missing 2 teeth. Here is another anterior segment with 2 teeth missing. It's not just replacing 2 incisors. It becomes much more challenging when the environment alters, when the teeth are adjacent to each other. Makes it a lot more difficult. When we've lost periodontal support at a bare minimum here between where the 2 teeth are going to be, we've already lost structure, let alone on the outer aspect. And then we start making things worse by listening to the hype of either clinicians that can benefit from you doing things their way or companies. The first part of this hype is when you take a tooth out, put an implant in and you'll be able to preserve tissue. That's not true. If you take a tooth out and you put an implant in the right place and there's adequate bone volume around it, maybe the tissue will stay where it's supposed to. Maybe. But the problem here is there is no guarantee that that will be the case. What I can guarantee is that during healing you will lose bone volume on the facial. You can't stop it by placing an implant. Arugio was able to show us in conjunction with Lindy that you lose this bundle bone that's adjacent to the tooth when you take it out, and placing an implant won't prevent that. Well, if that bundle bone consumes the whole volume of the facial plate, you've got a serious problem. A serious problem. And placing it to the lingual or placing it anywhere else won't always save you. And then the papilla, as Mario accurately pointed out, is not bound to the implant that you place in. The papilla is associated with the height and quality of bone on the teeth adjacent to where you're placing the implant. So it's much more important that you extract the implant and preserve the integrity of that bone, extract the tooth and preserve the integrity of that bone, than it'll ever be to put a tooth in or an implant back. That's much more important. So what we've seen is the development of protocols to address this. These protocols can work as well. Take the tooth out, allow for some degree of healing within the bony space, whether it's soft tissue recovery or whether it's at least partial bony recovery. But you can place an implant that's stable and then cover it with some autogenous bone and a material that resorbs at a slow rate, and cover that with the membrane and then allow it to heal. That sounds to me a lot more complicated than take a tooth out and put an implant in. So these protocols, the science shows improved outcome predictability. What it doesn't say is requires a better clinician to perform the procedure. You have to be a low-risk clinician intervention here in order to allow it to work the way it's supposed to. And when we read articles done by some of the world's premier clinicians that say, in our hands, this procedure has great outcome, don't forget it says in their hands. Controlled environment, controlled clinician skill. Not everyone will be able to achieve the same outcome because not all clinicians are the same. So really interpret the literature in a manner that's conducive to your skill set coming with it. Once you've been able to do that, sometimes it makes sense to wait. I heard a speaker not long ago say there is no indication for conventional implant placement anymore. Well, in my world, if you do a graft, I see no reason to rush the graft. It's not about the implant here, it's about the graft. You need to allow the body physiologic time to heal. That's a non-negotiable in my world. If you negotiate, you have a problem. So what I can tell you is we wrote an article at the last consensus conference that related more specifically to aesthetics. But we were able, I'm going to give you an interpretation that relates to implants in general. Satisfactory outcomes are achieved irrespective of the timing of the implant. The problem is how often they occur and how predictable they are. Not that you can get a successful outcome, there's no question. But as you accelerate the procedure and increase more protocols that have to be performed as part of that procedure, each one of those elevates risk, requires a better clinician, a better understanding, more experience, and a higher degree of education. If you are going to maintain the quality for the patient, this is a commensurate upswing in what's required. And the same goes for the restorative dentist. The literature would say you can immediately load an implant. Well, sure you can, but was the implant immediately placed? Or was it placed in a healed ridge? Or is it anterior or posterior? What I can tell you is we looked at this also, David Cochran and I, and we decided that we needed to write something about the quality of the clinician. The clinician here is the most critical factor, because if the implant is placed in a healed ridge, in the right place, and you have a good clinician, it's readily restored and it's not going to be a problem. However, if the implant's in the wrong place and you superimpose an accelerated loading protocol, you increase the risk of a catastrophic outcome for the patient, and that's not good. You would be better off waiting. Wait 6 to 8 weeks. Allow it to heal, and then intervene with minimal risk. I propose to you that this is an aesthetic restoration. Even though it's been placed in the back of the mouth, this is no less aesthetic than I would see in the anterior. It's an aesthetic 3-unit fixed partial denture. It's because the implant's in the right place. Whether it's at the front of the back of the mouth or the back of the mouth, doesn't matter. If it's in the right place, it will be both aesthetic and functional. And for the sake of 6 to 8 weeks, I don't understand sometimes why we risk the outcome. That's not a long period of time. So we can summarize here by saying, yes, you can immediately load an implant, and you can get a good outcome again. The problem is accelerated load, especially in an implant that's been placed according to an accelerated protocol, doesn't jeopardize the implant but can jeopardize or increase risk to the outcome. The risk might be recession of the tissue that you don't anticipate, which brings an aesthetic complication. Unfortunately, the implants continue to survive. But aesthetic risk is the major complication that we deal with because we know implants work. And even if they're at the back of the mouth and they're not in occlusal disharmony, implants aren't so much of a problem. But when the patient sees the problem, we've got a much more complex issue. We wrote an article in the first treatment guide, myself, Will Martin, and Professor Boozer, going back almost 11 or 12 years. And it's been cited everywhere, all over the world. Nothing new here. All we did was put a lot of factors in the one table so that the clinician could go through these and not forget them. We have seen so much use of this that the new treatment guide that's about to be published, Treatment Guide 10, includes an update of the aesthetic risk assessment. What has changed in the 10 or 12 years since we wrote the first one is really how we look at the width of the edentulous span, how much bone is required around an implant. And it's increasing from a 1 millimeter circumferential to a 2 millimeter, or somewhere in between. The closer you are to 2, the better off you are in terms of avoiding risk. It doesn't make the implant last better, but it'll help the tissue around it perform over a longer period of time. The facial bone wall, I argued with them, I don't think a millimeter is enough here. It's really the minimum number that is predictable. We are much better off with a larger number, and then the expectations of the patient. What I can tell you is I don't worry too much about smokers if we're putting an implant into healed bone, because I'm not asking for the vascularity to recover too much, and that's really what smoking influences. But if we have a smoker, we don't graft until they stop smoking, because for the graft to heal, angiogenesis must occur. And smoking influences angiogenesis. If you already have the blood supply, it's not so big an issue. This is a patient that I would try and avoid at all costs. A patient with high expectations and an unrealistic approach. I'm sorry to all the girls in the audience. There are boys that are just as hard, but this just happens to be a girl. And she was impossible to treat. I want my teeth back. You owe me my teeth. I said to her, well, you shouldn't have stood so close to the horse. And I don't owe you anything. And I walked out and sent my assistant back in with a note saying, we won't charge you today. We'll recommend you go and see somebody else. This is all about the psychology of treating the patient. Then she started to cry because she thought I was abandoning her. I said, I'm not abandoning you. Well, I am now, but I wasn't up until then. And then soft tissue, mucosal phenotype. You know, we hear gingival biotype over and over again. We've been saying it for 20 years. It's really mucosal phenotype is the thing that people are talking about now. What we do know is thick tissue supported by thick bone will respond appropriately. Thin tissue supported by no bone is at risk, high risk of a negative outcome. That's an important part of what I look at. And then we know that replacing two teeth is if they're adjacent, that's much harder. But if they're adjacent and non-symmetric, in other words, I don't really mind two centrals. I really don't like working with a central and lateral, and hate a canine and lateral even more, because the teeth are not the same. And then we have to look at the patient and understand sometimes these deficiencies are very small but very critical. In this patient, we have a facial deficiency that needs to be addressed if the implant is going to be placed at the appropriate inclination. This one, I think, is self-explanatory. It's not the same. A vertical defect where you have lost supporting tissue is very difficult to treat, because you're going to try and get volume in 3 dimensions, height and width at the same time, tension-free closure, surgical complications, very difficult to do. The bottom line is you really should address all of these issues with each patient. Make a straightforward circle around where the patient is, and I would suggest to you, you see 3 there that are in red. If you have 2 or more teeth adjacent to each other, if you have less than 1 millimeter of facial bone, or if you have an unrealistic patient, I'd recommend you refer the patient to somebody who has a higher degree of experience with dealing with that kind of patient. Now, the last 5 slides, avoiding complications, use the correct implants. I hear people say, we are a whole bone level practice. I can't think of anything more stupid than a whole bone level practice, because there are definite indications for a tissue level implant. It's biomechanically superior. The only reason not to use it might be aesthetics and space. Sometimes you need that little bit of space. But this tissue has this implant has all the evidence there is. And it can be restored aesthetically if you have a thick tissue and you have a good clinician to put it in the right place and a good dentist to restore it. The key here, single stage. If you're the patient, would you prefer 1 or 2 surgeries? I mean, really? That's a simple question. Its shape is more conducive to both patient and dentist understanding, and procedures are not challenging to perform. So I will show you, these are 10-year follow-up photographs of a canine and a central incisor. Both of them restored on tissue-level implants, and if I didn't tell you they were tissue-level implants, one cemented to a custom abutment, one directly screw-retained into the implant, I think you'd agree there's nothing wrong with these restorations. If I treated them today, I'd probably use a bone-level implant. Not because I think the crown could be better, but because I think risk to outcome could be reduced by using an implant that's more forgiving in this environment. So when is it more forgiving? When the patient carries a high aesthetic risk. I think a bone-level implant is advantageous. When you have restricted space between teeth or between arches, a bone-level implant is advantageous because the crown starts narrower than the diameter of the implant. Whereas on a tissue level, because you have emergence and the crown goes to the edge of the implant, the crown starts bigger than the footprint of the implant in bone. If we have the same volume of space, what that means is there is more implant and crown and less tissue for the volume that we're working with. With a bone level, you've got more tissue and less implant and crown. That's better for the tissue, that's better for aesthetics. The problem is, as it gets smaller, it gets weaker. So you as the clinician have to decide where it becomes too weak, because we always want more tissue, but it comes at biomechanical predictability expense. That's what you have to look at. So patients that carry, my dog came back for a brief minute. So the key here is this bone level implant starts narrower, and you have more control over the material and the shape. So you can keep it small in the submucosal regions until it needs to be the right size, supporting the mucosal margin. By doing so, you get more volume of tissue and less volume of crown. So effectively, you turn a thin mucosal biotype into a thick mucosal biotype because you have to look through more tissue to get to your restoration. That's really an important thing. But as it gets narrower, it gets weaker, and you predispose to mechanical failure. So be aware. Patients like this, though, there is no question. I showed you this patient before. You see the full smile on the left. You can see the shadow. Thankfully, the patient has yet to see the shadow. Hasn't complained in 10 years, but could complain tomorrow. There is no way of fixing this. That's the tissue level polished collar showing through a thin mucosal biotype. Can't cover it with composite. Can't cover it with a graft. It's a problem if it becomes an aesthetic issue. Essentially, it can result in the crown needing to be removed. If I treated it today, we would use a more tooth-colored, narrower material that gave me more tissue for the same volume and less problem with the dark material below. So that's where we should be. I want to finish with 3 slides that emphasize prosthodontic volume. I hear all the time about surgical volume, how much bone an implant needs in order to maintain health. There is a prosthetic volume as well. The crown and the emergence need space to perform properly, to have the right emergence profile and the right interdental shape and form. This little white slither here is very important. Each crown and each tooth needs its space in order to be predictable over a lengthy period of time. So if we move that across and I show you a single crown, 5 years of follow-up, the key here is that we have the right shape and form in the submucosal regions to perpetuate long-term health and integrity of the periodontium. That's what gives us success. Now, just before we get together and talk a little bit after the coffee break, I think it's important to tell you that there is an evolution going on. Many things are changing that will allow us to be more predictable and to avoid problems as we move forward. I want to spend a little bit of time after the break talking to you about how they can help us with planning to reduce complications rather than have to manage them. Thank you for your attention.